And we're live. Hello, it's Bill, the knee pain guru. Welcome to this week's episode of the Ask Dr. Beck show. Good morning, Dr. Beck.
Good morning, Bill. Good morning, everyone.
How are you? How are things?
I'm all right.
Good.
I don't know if you can see, I've got one of my puppies in the background. She's on the show today. Her name's
Juma.
Juma. It is short for Jumamosi, which is Swahili for Saturday, which is the day of the week she showed up in my life.
Got it. Okay. Well, cool.
Yeah.
Okay. Lots of insights from last week with the going over jaw tension and teeth stuff. And you said you're going to have some interesting stuff for us to chat about today.
Well, I want to do a kind of a tangent because of things that showed up in my practice this week that I realize the world probably, let me say, it probably isn't just explained in plain English.
Okay.
And so my wife runs a thermography practice in our office.
Okay.
And thermography basically is digital infrared images that you can take of the body. It is one way that you can do a breast health screening.
Okay.
And so I want to talk about breast health from the physician standpoint.
Okay.
And primarily this is geared toward women. Breast cancer is higher incidence in them, but also geared toward men. And let's go from the doctor's perspective of you come in for your annual exam. And what I'm going to do is I'm going to spend 3 minutes looking at and palpating your breasts, 3 minutes out of the year.
Mm-hmm.
And I'm going to ask you, have you noticed anything different about them? And if you give me a confused look, then what it tells me is I don't know, because I don't really feel my own body from the inside and from the outside, which makes my job incredibly hard to get right and to get right consistently. Okay.
Mm-hmm.
So I want to talk about this from the owner of the breast. And theoretically, that's all of us that are alive.
Mm-hmm.
Breast tissue is supposed to be moving. And so there shouldn't be anything in it that causes it to move in a non-smooth pattern. Now, this is unless you've had surgery, which would then make it move differently. So let's take you optimally. Yes, Bill?
Surgery, meaning scar tissue is building up.
Scar tissue is building up. Yes, yeah. Exactly. Okay. So let's take you normally. When you stand, arms at your side, your breasts are going to have a certain shape.
Mm-hmm.
That certain shape is you. When you move your arms, your breasts are going to move in a way that is normal for you. When you, for example, are doing a handstand, your breasts are going to do whatever is normal for you. When you're lying on one side or the other, again, breasts move normally for you. The thing of it is, as a physician, I see that, again, 3 minutes once a year. That's it. And so I'm making an assumption about your normal.
Mm-hmm.
You see it all the minutes or feel it all the minutes of the year. And
Okay.
So your input as the owner of the breasts helps me a great deal. If you can come in and you can say, hey, every month when I do my self-exam, they move the same as they always have. That means theoretically I have not much to look for. But if you come in and say, in the last 2 months, they've been moving differently, I know I have to really up my game and try to find out why.
Mm-hmm.
Okay. So first part of your self-exam, and this is something that you can do on your own in a mirror or have someone else help you to do, is simply move with your breasts exposed and let someone see them and see if they move the way they always have. Okay.
Mm-hmm.
That's the first part. Second part is you need to palpate. You need to look for things that don't feel like they did before. You're going to know if your breasts have hormonal changes and the things that you feel go up and down with your hormones. You're going to know that because you felt them a number of times. You're going to know if something feels different that doesn't seem to change with hormones. Those are the things that we need to know about as physicians. And then you're going to be able to guide us to that place. If something is tender, we obviously need to know. Tenderness is usually not normal in the breast, especially on palpation. And so there are things that we can do to help the tenderness, but it also guides us to look for something that may be abnormal in that area. Okay.
Mm-hmm.
All right. So let's just say that you do all of your self exams. You feel your breasts on a daily or weekly basis. And so you have a really good idea of what they're like. And to you, they appear normal. Okay. So that's step number one. Step number two is if they appear abnormal, you're going to enter into the medical system. The medical system uses the mammogram as its gold standard, which means you're going to have a mammogram. That's what everybody's going to recommend. Mammogram has some risk with it. It is a radiation source, and repeated mammograms, at least the thinking is, can do damage to the breasts over time. What I'm going to recommend as a physician is you need one. You need one because if something goes wrong, we need something to compare it to.
Establishing a baseline.
Establishing a baseline, absolutely. That theoretically is you and normal tissue.
Mm-hmm.
Okay. The ways that we can look at the breast, and they're changing with some rapidity as technology improves. But mammogram, we have things called a 3D mammogram. We have CT scan. We have MRI. We have ultrasound. We have thermography. We have palpation. Palpation theoretically is always going to be there. But what they didn't teach us in medical school, but what I learned in becoming a certified thermographer, is that every imaging that we can do out there has things that it does really well and things that it is blind to.
Mm-hmm.
The particular kind of imaging can't see one or two things, but it can see all the others. If you have more than one image, you cover your bases because they're not blind to the same things.
Mm-hmm.
So what I recommend to folks is you have a mammogram first time through, and then you have another kind of image. And it doesn't matter. The choice is up to you. We do thermography, so I'm going to recommend that, and we'll talk about it from that aspect. When you get two images, two imaging types that show normal breast tissue, healthy breast tissue, you can rest assured you're probably really statistically on the low end of having any cancer because you've had two different kinds of scans. Then you choose the scan annually or every other year that matches whatever you would like to do. For us, it's thermography. Thermography doesn't use radiation. We're not putting your breast in a vise like a mammogram does. And it's pretty consistent at showing, again, types of cancers. So it can give you a lot of early warning. Let me just think here. Then let's just say that your scan comes back abnormal. What cancer is in the United States is a fear-based system. So you have cancer. Oh my goodness, this is bad. You're likely to die in 2 or 3 days. So we must do surgery tomorrow morning. And what I tell everybody is if you have a diagnosis, it's a diagnosis. Take a deep breath, then take another one, then take a third. And after that, you can start making decisions and figure out what's right for you. Listen to the advice of the medical system. It's advice, but figure out what's right for you. And I think that's it. That's my little tangent.
Okay. If there is anyone, we have a few people online right now. If you have questions and would like to submit them to Dr. Beck, you can type those in the comments or the live chat. And yes, you're able to do that. Let me see. I have some questions.
Okay, I'm ready.
So the mammogram, from your perspective, you're looking at using the mammogram the first year you would do a mammogram?
Sure. Let's say age 40.
Okay. And then every year after that, you're almost doing like a different scan to create a contrast, or?
So that's one way of doing it. What I recommend in our practice is you do a thermogram every year. And remember, we run a thermography practice. So part of that is supporting the business.
Mhm.
But a thermogram looks for tissue that has extra blood flow. And so cancer has extra blood flow. So we can usually see if something's going on and tell in a thermogram, often many years before a mammogram would show a mass.
Oh, interesting.
Okay. So that's why I recommend that. And then, every so often, let's say every 5 to 10 years, again, it's your choice as a woman or a man, you get another mammogram. So you're not exposing yourself as frequently as if you got them every year or every other year.
Okay. And maybe if we could briefly cover the difference, because I got the mammogram, I got CT scan, ultrasound, thermography, and MRI.
Yep.
The different types. Were there any more?
Nope. I mean, there may be more, but I'm not aware of them.
Oh, okay. But maybe we could brief over those and go over the you said the advantages and then blind spots of each of those, so people can kind of get a better understanding.
I'll share with you what I know, and the caveat being I certainly don't know everything.
Sure. So mammogram.
So let's talk about mammogram. Basically, it is a very specific X-ray of the breast tissue.
Okay.
X-rays show up in grayscale. That grayscale is going to show you things that are calcified as being white and things that are air as being completely black. And so we've got what's in between. And if the radiologist, who's the person who's interpreting it, sees something that they've been trained to say, hey, this looks like cancer, then they can help mark it, and it can either be biopsied or removed. Okay. So pitfalls there, it's radiation. It's ionizing radiation. It's an X-ray machine. And there are ways that you can safeguard yourself against that ionizing radiation, but it still changes and alters the DNA of the cell. So there's talk that it may cause cancer in and of itself, especially if you do it often. Okay.
Got it. Okay.
And I haven't gone through and memorized all of the types of cancer that each one is blind to. Just recognize that each thing that I'm talking about has things it doesn't see super well and other things that it does. Okay. Ultrasound basically is like sonar for a submarine. It puts out a ping. The ping bounces off something and comes back and is picked up on the head of the ultrasound machine. And so what you see is reflections. Okay. And so if you have a fluid-filled cyst, that fluid absorbs most of the ultrasound's ping. It shows up as a dark spot. So that's great. You can see cysts. The problem with an ultrasound machine is if there's a cyst, anything behind it is in a I can't see zone. Okay, so the only way you can get an ultrasound to work really, really well is if somehow you could get all the way around something. And in theory, if it's closer to the nipple, you may be able to move the machine all the way around, but if it's closer to the chest, you can't. So ultrasound, just by the technology, can see some really cool things, and cancer masses show up as a different outline and a different shape than something like a fluid-filled cyst. So again, it can be helpful. MRI uses its magnetic resonance. And so what it does is it uses a very strong magnet to stand all the water cells in the body up on end and then knocks them over. It's wonderful for seeing things like muscles, ligaments, and tendons. It can also be used to see bone, but it's not quite as good, but muscles, ligaments, and tendons. So if you have something going on the chest wall, an MRI is a wonderful way of getting a good picture of that. CT scan, computed tomography, basically it's X-rays taken in layers of the body and put together so we can slice through what's going on. Now, the only problem with at least current technology of CTs and MRIs is that they take slices.
Mm.
The slices are usually a few millimeters apart.
Mm-hmm.
So as long as what you're looking at falls either within a slice, okay, or it's big enough that it falls within a few slices, you see it. If what you're looking at is smaller than one slice or falls in between slices, it's basically invisible to you.
Mm-hmm.
Technology continues to improve, but that's where we're at the moment. So very small things like early cancers, harder to detect with those kinds of images.
Would a CT scan expose you to more radiation than an X-ray?
No. I honestly have to look it up. I think the answer is yes, but it's not by a large amount.
Okay. Got it. I think that was it. That was good. I took some notes. We'll put it in the show notes.
Perfect.
For it. But yeah, that was good.
And go ahead.
Step 1 was a self-exam if it appears normal. Step 2, if it appears abnormal. And then you went into the different types of mammogram, CT scan, ultrasound, thermography, MRI. Was there a third step in there? I don't know if I got
Breathe.
Breathe. Got it.
Breathe. Yes. Breathe and try to understand your options.
Okay. Cool.
And what I wanted to add in is that this isn't trying to take away from anything that we do in medicine. Mm-hmm. Just recognizing that often we don't give full disclosure. That's the reality. We don't tell you what this thing can and cannot do well.
Mm-hmm. And what I really heard you saying at the beginning is there's a level of awareness that people generally don't have about their bodies, and they're going to a doctor that's only going to take 3 minutes to look at something that can change the course of your life.
Yes.
So by taking more responsibility, being more aware of knowing what's going on, more connected and in touch with your body, that this can really, you can use the physician as a player on your team, so to speak.
Yes, very much so.
Yeah. Okay. Cool. Well, we had a question that came in.
Okay, fire away.
It came in from Kathy. Said, can a misaligned first rib cause neck pain? Yes.
Next question.
The man of many words.
All right. So the deal is we have muscles that attach from the first rib up into the neck, or from the neck down to the first rib, however you want to look at it. And those are the scalene muscles. Mm-hmm. They're in the current medical textbooks are 3. In the old medical textbooks, there are 4. There's one that it acts like a ligament, and so they kind of took it out of the new ones. Mm-hmm. But the anterior and middle scalenes attach to the first rib and go up into the neck. So if first rib is stuck out, not moving correctly, then yes, it can cause tension in the neck and pain in the neck. Movement issues in the neck.
Mm-hmm. I think we covered this last week. I think we definitely talked about the scalenes. Maybe that was a week before.
Yeah.
In the past couple weeks.
Yeah, and if the scalenes get tight, it can also put pressure on the brachial plexus, which is the nerve bundle coming out of the neck that controls the arms. Mm-hmm. So you can get arm numbness, weakness, tingling, sensitivity, all from something that goes on in the neck.
Mm-hmm. Yeah. Kathy says, thanks, guys. Cool.
Good.
Let's see. It might be a good. We might call it a day today,
Okay.
and push off the digging into the jaw
Do
because
more dental stuff next week. Yeah, that's fine.
yeah, that would be good because there's a lot of insights I've had since last week and would like to dig into those and don't want it to push it another 45 minutes
Sure.
on the other side of this because we can really go down some rabbit holes with what's going on with the body.
Yep.
So that was great. I appreciate that on the distinction with those different types of scannings of the body. Thermography. One more question.
Sure.
Someone would specifically search for thermography, a thermographist, thermographer.
Yes.
Okay.
Yeah, and so I'll give you maybe a 3-minute spiel about thermography. What it does is it takes digital infrared pictures with a camera whose sensitivity is most acute in the human body temperature range.
Mm-hmm.
Okay. So there are thermographic cameras out there that can take pictures of buildings, that can take pictures of fires, and show you many different temperatures. The camera that we use only works from, let's say, 94 to 101 or 102.
Mm-hmm.
Everything else shows up as either black or white for that camera.
Mm-hmm.
But within the human body range, we get a big spectrum of colors.
Mm-hmm.
And then there are dermatomes. So those dermatomes are where the nerves come out and supply the skin. Mm-hmm. There are also thermatomes where nerves come out and relate to internal organs or other things from the skin. And so someone who's trained to read a thermogram can say, oh, it's hot, cold, whatever over this area. And that would indicate this or that going on. Mm-hmm. Okay. So a thermogram is a picture of the whole body or parts of the body. From that picture, we can then see physiology, the reactions of physiology. Mm-hmm. Okay. So X-ray, CT, MRI, those all show anatomy, but they don't show physiology. They don't show how something's working. Mm-hmm. A thermogram shows you the effects of how something's working. Okay. And if we go back to breasts for a moment, again, something they didn't teach us in medical school, and we'll take you for an example. Bill, your breasts, yours, absolutely, have a unique to you, shared by no one else in the world, blood vessel pattern.
All right.
Okay. So if I have something that can see your blood vessels, and I take a picture, and then I take a picture a few months later to prove that nothing has changed where those blood vessels sit in your breasts. Mm-hmm. So I overlaid them and they match. Mm-hmm. Now, by taking pictures of your blood vessels, which a thermogram can do, I can see if something's growing, because if something's growing or shrinking, it's going to change the relationship of the blood vessels.
Sure.
Which is kind of cool.
Yeah.
And because it's unique to you, it's specific as well, right? If there were 10 different patterns and we all shared them, you could get a mix-up.
Right.
But yours are unique to you.
Uh-huh.
So that's one of the things that a thermogram can do. Now, a thermogram can't see things that are hidden. So, for example, your brain is effectively hidden by your skull. I can see things going on the surface of your skin, mm-hmm. of your head, but I can't tell from a thermogram what's going on in your brain. Because the camera, I can't get it there.
Right.
Okay. Your prostate, for example, I can't get the camera there.
Mm-hmm.
So I may see reflections, but I can't see the actual thing.
Oh, so it's a depth. It's a depth of
depth, and then how the thermatomes show up, and then what is available to be seen. Right? If you have a problem with your eyes or your eyelids, I can see that. Optic nerve and further back in the brain, I can't. If you have a problem with your ears, I can see your ears, the pinna, the outside, but I can't necessarily see if you have an inner ear infection, again, because the camera isn't able to see those things.
Got it.
It sees the surface, not the depth.
Mm-hmm. Cool. Okay.
Yeah.
Awesome. Well, anything else?
That'll do it.
Okay. For those that are watching the replay, feel free to type in your questions, and we use those on future Dr. Beck episodes. You could also go to the Comella Foundation website to the Ask Dr. Beck link, and you can submit your questions there. Make sure to give the video a thumbs up, like, and subscribe to the channel. Charlie, thank you. Appreciate your time. Have a great day, and we'll see you next week. Same time, same station.
Sounds good.
Okay. Bye-bye.
Bye.